Hello and welcome. My name is Tim Wilson with Blue Sky eLearn, and we're pleased to host today's program for the University Risk Management and Insurance Association, or URMIA. Thanks for joining us today for this live webcast, Impact of COVID-19 on Higher Education Employee and Student Health Programs. Just a few notes before we get underway. First, you may adjust your audio using any volume settings on your own device. A feature that we encourage you to use is to send in a question to our presenters. On the right side of your screen, you'll see a box labeled Q&A. To send in a question, click in the text box at the bottom of that, and then type your question. When finished, hit the send button or hit enter on your keyboard. All questions that you submit are only seen by today's presenters and will be addressed as time allows at the end of the presentation. If you wish, you may enlarge your screen for the presentation portion of the webinar using the icon with 4 arrows in the ribbon above the slide deck. And at the end of the program, we ask that you please complete a brief survey. This will help URMIA plan future webinars. And with that said, it's now my pleasure to introduce today's moderator, Michelle Smith. Michelle is the Senior Director of Meetings at URMIA and has been working on regional and annual conferences, the launch of podcasting, and learning about risk management since joining the association last year. Michelle is not, however, new to higher education, working previously with your college union colleagues on campus. So it's my pleasure at this time to pass the microphone over to Michelle Smith. And Michelle, the audience is all yours.
Thanks, Tim, and hello to all of you. I'm so glad to be here today representing URMIA's national office. Thanks for joining us. Before we start, I'd like to encourage you to use the URMIA website fully as part of your membership. Topics like this can be found in the URMIA library. I'd also want to alert you to our upcoming schedule of URMIA COVID-19 conversations on Zoom and URMIA webinars just like this one by visiting www.urmia.org/events. So let's get rolling with today's webinar. It's my pleasure to introduce you to today's speakers who have full biography information online. We have Andrew Godfrey, producer with Risk Strategies, or Liz Marks, Senior Strategy Consultant with Academic Health Plans, which is a division of Risk Strategies, and Mark Billingsley, a Senior Consulting Actuary from UHAS, also a division of Risk Strategies. As Tim mentioned, we welcome you to submit your questions at any time during the presentation, and the speakers will try to address those as they come up. Certainly look at those again at the end. And now I'll turn it over to Andrew.
Thank you very much, Michelle. Good afternoon or good morning, everyone. Thank you for joining us. My name, as Michelle mentioned, is Andrew Godfrey from Risk Strategies, where I'm a producer in the Employee Benefits Boston office. Joining me today is Liz Marks and Mark Billingsley of Academic Health Plans and United Health Actuarial Services, respectively, both divisions of Risk Strategies. Risk Strategies is a specialty insurance broker headquartered in Boston with 80 offices throughout the country. One of our largest specialties is higher ed, and today we bring that experience to you. The agenda for today is as follows. We're going to focus on the role of risk management in providing health insurance programs to faculty, staff, and student populations. Mark is going to cover the expected impact that COVID-19 will have on claim costs, and Liz is going to cover the expected impacts of COVID-19 on your covered student population and how that may impact the cost and management of those programs. Our goal today is to help you begin to think about ideas and next steps to manage both of these plans moving forward. Tim, if we could start with a few polling questions to get people thinking about the plans that they manage.
And the first polling question is on your screen. Is your health plan fully insured or partially self-funded? And to participate, click on the little radio button to the left of your response. And I should pass along that your participation is anonymous on these. Now let's go ahead and end that. It looks like 75% say fully insured. And let's bring up the next polling question. What is the approximate number of participating employees in your health plan? And we have 4 options for you. Okay, let's go ahead and end this one. Overwhelmingly, over 1,000 is the most popular answer. And then we have one more polling question for you at this time, and it is on your screen now. Of your enrolled employees, what age bands would the majority fall into? And again, we have 5 options this time. And you can, on this one, you can select as many as necessary. Most popular answer, 26 to 35 years old. And I'll pass it back over to you, Andrew.
Great. Thank you so much. Thank you for taking the time to do that. That gives us a very strong idea as to what we're dealing with from an audience. Thank you. So why should risk managers be concerned with employer-sponsored health plans? Well, for starters, these programs are an extremely important aspect of overall employee compensation. Aside from salary, these programs consistently rank among the most, if not the most important benefit to recruit and to retain employees. It's also expensive. The $10,000 to $13,000 averages shown here may vary depending upon your specific region or your insurance market, but generally speaking, this is what we see for employer costs per employee on an annual basis. Without management, these costs could increase dramatically and in a lot of times outpace other areas on your budget. To tell us more about the impact of COVID, I'll turn this over to Mark Billingsley.
Thank you, Andrew. It is my honor to add my comments to the discussion today. Over the last 10 weeks, my colleagues and I have been monitoring the statistics and public data to understand the progression and trajectory of COVID-19, particularly as it impacts the cost of healthcare plans. So how do we look at COVID-19 impact on various types of plans? As actuaries, we search for and mine available information in order to set assumptions. We attempt to anticipate relative impacts where relationships are logical. Anecdotal evidence is sometimes helpful, but usually insufficient. So we search for supporting information wherever possible. Related to the impacts of this pandemic, we tried to identify both the spread and the severity of the infections. The assumptions related to spread are often difficult to measure and define. We could measure at any of the various stages and or levels of impact, including mere exposure to the virus, positive infection tests, contracting symptoms, receiving professional medical care, which may include more than just simple confirmatory testing. We could measure individuals under quarantine, hospitalizations for COVID-19, intensive care confinement, being on a ventilator, or even death related to the pandemic. Attempts are being made to measure various stages, but those cases requiring professional care and actual deaths appear to be the two levels that are most consistently tracked. The severity of assumptions attempts to combine the various levels of symptoms with the medical costs for treating each level. We'll talk about severity a little bit further in a few minutes. The capacity of the healthcare system to handle the exposure was initially seen as critical. Some geographic areas, particularly in the Northeast, have seen much larger impact than others. More recently, in many areas of the country, the concerns have been how to keep medical staff employed when so much non-emergency care and other conditions are being avoided and delayed. The other concern about capacity is how well the system will be able to cope with the pent-up demand once other conditions are rescheduled. We anticipate a surge in the demand for care as COVID-19 concerns subside. Cost and capacity may also cause some patients to look elsewhere geographically for the availability of providers where local providers are currently unavailable or unacceptably expensive. One final assumption I'll mention is the availability and timing of and cost of vaccines, along with the effectiveness and acceptance if one or more vaccines do become available. Hang on a second. The demographics of a particular group is also important to understand and predict the severity of healthcare costs due to the pandemic impact. Age is the most predominant indicator of the impact of COVID-19. Unlike influenza, which actually impacts children most acutely, the impact of this virus increases dramatically by age. And we'll look at that a little bit more in just a minute. We also know that males are roughly 15% more susceptible than females. And since most severe conditions from this virus impact the lungs, smokers are also at a higher risk than non-smokers. Individuals with other specific medical conditions such as diabetes, obesity, and heart issues are also at a higher risk for severe cases of COVID-19. You can see that age is a factor in the symptomatic infection rate. The levels shown here are consistent with an ultimate level of 2% of the population having symptoms. But clearly, the older age groups are much more susceptible to this virus. Even more dramatic, though, is the actual severity of cases. This graph does not have a legend, but it just is intended to show the relationship and severity of cases by age. So as individuals are impacted by this virus, the older individuals, the cost for older individuals is much higher. Combining these two, you can see the dramatic cost difference for a population by age when you combine both the incidence rates by age and the severity of the care. So age is clearly a very significant impact for this pandemic. Current statistics indicate that the number of reported cases is between 1.6 and 1.7 million. This puts reported infection rate for the United States at about 0.5% currently. This will continue to grow, probably reaching 1% by the end of the year. It is believed that tens of millions of people have actually been exposed to the virus with little or no symptoms. If that's the case, the infection rate may be substantially higher than 1%, but still consistent with a 1 to 2% symptomatic infection rate. For the reported cases, about 80-85% have mild symptoms and do not require hospitalization. For those hospitalized, about 25% require intensive care, and a portion of those will also need to be put on a ventilator. As previously mentioned, the most significant indicator of severity of the disease is the age of the person infected. A little deeper discussion of the delay and rebound of care is appropriate. There are many healthcare services for which treatment already started to be reduced even before extensive public policy restrictions were put in place. These include joint surgeries, bariatric procedures, routine medical, dental, and vision exams as a few examples. I have even heard of chemotherapy being delayed due to concerns about COVID-19. Reductions in these procedures were already being delayed by mid-March due to patient concerns about exposure. Then medical providers, particularly hospitals, started postponing care due to the concerns that the system would be overwhelmed with COVID-19 patients. This became particularly true when some global locations other than Wuhan, China, experienced outbreaks that started to flood local hospitals. Areas like Spain and northern Italy sparked significant concern. So the combination of institutional restrictions and patient hesitancy have led to significant reductions in medical care for non-pandemic conditions. Some reduction for non-COVID related medical care is still being seen today, as particular restrictions are being eased only gradually and as individuals weigh their own risk tolerance against the care that they would otherwise need. The deferral of care in the first half of 2020 will be very significant. In some cases, the care is not merely deferred, but eliminated entirely. This could occur because the care is no longer needed. Either the person recovered without care, or it's maintenance care that will just resume at the same level prior to the pandemic, and that holding coverage will just be eliminated care. Another aspect of the reduction in care is simply due to reduced travel-related accidents, as mobility, particularly automobile traffic, has been significantly reduced during this recent period of extended social isolation. On the other hand, there are also situations where delayed treatment may cause the intensity and cost of care to rebound higher than it would have been if it had not been delayed. I'll mention a couple of examples. Cancers may progress to a higher level due to either delayed chemotherapy or delayed detection due to postponed routine testing. Some joint surgeries may also be more extensive due to prolonged period of continued injury. Further, the additional stress from the pandemic, personal and financial challenges, and other dramatic changes in daily life may cause noticeable changes in the frequency and or severity of mental health issues. But overall, the health plans, but overall, for most health care plans, the decrease in care is estimated to be larger than the cost of COVID-19 itself. How this is observed in the claims experience for a plan will vary based on demographics, geographic patterns of the pandemic, as well as how the cycle corresponds with the plan year. For example, the deferral of care may be within one plan year, while the rebound may all occur in the following plan year. The impact on a particular population, such as students versus faculty and staff, may also vary. Again, geography, contagion within a community, and pure randomness randomness may all contribute to a higher or lower than average impact for any particular population. So I'll now talk about a few graphs which gives you a picture of what we're seeing. So the first thing, this first graph merely shows the baseline costs for a plan as if the pandemic had not occurred. And then the red line here shows the impact of delayed and or eliminated care along with the rebound due to pent-up demand once full restrictions are removed and individuals become more comfortable with the safety of the healthcare system. As previously mentioned, this pattern may also be constrained due to healthcare system capacity. The impact on a particular plan, just due to the range of severity of COVID-19 itself, is shown here. The three lines represent three different levels of incidence rate and severity. So you can see that the higher costs are expected to proceed for some time. And you can also see I've included a potential vaccine shown here as being introduced in July of 2021. Combining these together, you can see a very uneven pattern of costs over the next couple years. This is obviously based on a lot of assumptions, and the impact on any particular plan may vary, but we are going to see some very unusual patterns in medical claim costs over the next few years. The impact on student plans is obviously going to be a little bit different. I don't have any expectation that the deferral and rebound of care is any different for a student population, but obviously, due to the lower average age, the expected impact, direct impact of this pandemic will be significantly lower. Combining with the deferral and rebound of care, you can see again, we expect a peak during the winter next year, but the peak for this type of plan will be significantly lower, and overall it will be significantly less than the amount of deferred care in the first half of 2020. So Liz is going to dive into student plans a little bit further. Liz?
Thank you, Mark. And I think we have some polling questions coming up next.
And let's go ahead and share those polling questions. The first one, is your student health plan fully insured or partially self-funded? And again, a reminder to our participants that you can submit a question at any time by typing it into the Q&A pod on the right side of your screen.
Okay, looks like we have a 1/3, 2/3.
About a 2-to-1 ratio there. So let's go ahead and bring up the next question. And it is on your screen right now. Our student health plan enrollment process is most accurately described as, and we have 3 options. Well, it seems like the combination of the two is twice as popular as the other two combined. And let's bring up the final polling question for you. What is the approximate number of participating students in your health plans? Let's go ahead and end that. It looks like the 2,000 to 5,000 range is the most popular one here.
Great. Well, thank you. That really helps to know a little bit about our audience. And actually, the next slide. So let's think about, whoops, I think that's still marked. A little more slide here. Okay, here we are. Well, anyway, all of you, it's very nice to be here. Wait, we still have the wrong question. Sorry about that. I'm having a little problem going with the slides. Tim, can you help forward the slides for me? I apologize. Next slide coming up. Okay, here we are. I apologize for that delay. So one of my favorite subjects, student health plans, and thinking about the role of risk management, you know, as Andrew mentioned earlier, employers really have to offer plans as part of the benefit package. But why do we offer student health plans? Well, there are a number of really important reasons, and one of the most important is that healthy students become productive students. It's a generally held opinion that healthy students are more successful in terms of good grades and graduating on time. And if a student does have a health problem, doesn't get appropriate care at the right time, then the condition could worsen and ultimately having the student drop out. And of course, that's not anything that we want to have happen. We want to protect the university and students. Aligned with that, a big issue is behavioral health concerns. And I'm sure all you risk managers are worried about that. But as reported by Helpline, a 2014 survey found that 33% of students surveyed were having some kind of mental illness and suffering from serious depression. And a 2016 study reported that almost 40% of students struggled with at least one mental illness. A recent ACE survey with presidents and universities indicated that of the top 10 considerations, behavioral health is number 5, sorry. So obviously everyone's thinking about this. And the type of conditions that we're seeing in surveys, the top 3 are really stress, anxiety, depression, and insomnia and sleep disorders. Obviously for risk managers, there's concerns about campus violence and campus security. Another interesting point about student plans is the annual premiums are relatively low, at least compared to employer plans that range from $10,000 to $12,000 per member per year. That's a good thing, and being competitive allows a student to look at other plans, and if a student is not eligible for a subsidy on an exchange, a state exchange, student health plans are very competitive and designed to meet students' needs. Another important reason is the F1 visa students are required to have insurance, and that's something that's a really good reason to offer. In addition, health coverage for athletes. I know most universities already provide athletic insurance, but that just covers injuries due to sports activities, whereas it's also important for a student to have basic health coverage so that they can stay healthy and continue to play sports. These plans are designed to integrate across campus resources and within campus resources. So the student health centers and student counseling centers have a big role to play. And when students access those services, the costs to the plan are much lower than if a student would see an outside provider. And finally, there's an important point that it is a university and college's fiduciary responsibility if they offer a plan. The American College of Health Education in its Standards for Student Health Insurance Plans includes standard number 3, which is fiduciary responsibility. And this simply means acting and managing the student health insurance plan for the benefit of all students. So let's think a minute about the cost factors. Mark talked a lot about the claims costs, and even in student health insurance plans, claims are obviously the biggest part of that premium. Now, thinking that a third of you, roughly, or 25%, are self-funded, it's a little different because you're much more focused on managing those claims costs because the university ultimately is paying for those. In an insured plan, you're leveraging the risk onto the carrier, and so either way, you have less risk from that standpoint. But whether you're fully insured or self-funded, the key thing is that the rates are based on the specific claims experience, using a credibility factor. With smaller groups, typically underwriting blends claims for 2 years. Larger groups, it's 100%, and even with self-funded plans, it's likely you could be using just 100% credibility on the most recent year. Whether you have enrollment is type waiver or voluntary or combination, I think most of you attending indicated you have some combination. It might be type waiver for international and voluntary for domestics, but type waiver enrollment obviously helps mitigate adverse selection. And then we have the general unpredictability of student health. And why is that? Well, the population changes every year. We have students new coming, we have students graduating. The good news about that is you don't have an aging of the population. So the student population never ages as a whole as it does with employer plans. The unfortunate news about that is we don't know if the new students coming in have higher risk or lower risk than students going out. So it's hard to predict. We're really each year underwriting on the basis of a new group of students. The impact of high cost claims is very unpredictable, and I've seen cases where you have 1 year with no high cost claims and another year with 3 and 4. So it's really going to skew the total claims cost for that year. And because the premiums are relatively low, the impact of the high cost claims hits much harder than it would on employer plans. And another factor is how many international students you have. The data indicates that international students are not high utilizers typically of student health plans. And this is probably because they come from other countries where they're not familiar with the US healthcare system and they don't access care in the same way. So to the extent that you have a large international student population, that group will obviously have lower claims and help to support the higher than expected claims, higher claims expected from domestic students. Another key factor is the services provided by student health and counseling centers. For example, most student health centers provide excellent primary care. The counseling centers are there to be able to manage the plans very effectively. And then they basically, the charges from the student health center are much lower than going out to an outside provider. And finally, when the renewals were done for 19, 20, 21, typically they were done early in February and March. And really, COVID was just emerging at that time. And we don't have, the decisions were made early, and we did not have any available claim data. So when we think about all of these factors, what will change under COVID-19? And actually, not really much. We're still going to deal with these same issues. And now we're just concerned about what the cost is to the claims. So if you look at the next slide, this is data from a group of block of student business we have. It's about 45,000 students, and it's very immature, but I thought it would be interesting to look at some historical experience to see where we think claims might be going. Mark mentioned that on average, we weren't going to see a very large increase in costs over time from the student health population. And this shows the trending of claims by benefit services. So if you look at the top line, professional, you'll see in the first quarter of 2020, claims are actually going down slightly, and this is the delayed care that we talked about earlier. The pharmacy looks, the blue line looks pretty level, but we would expect those claims to go up if students aren't accessing the health center, if they're studying off campus. They may go to outside pharmacies where the prescriptions are more expensive. The facility outpatient, we see it has a downward trend. Again, these are elective surgeries, knee surgeries, and musculoskeletal injuries that we see a lot in student health. And again, there's a downward trend here. And inpatient, you'll see, looks like it's going up slightly, but we don't expect big hospitalizations in this population. So that may be just an anomaly, or maybe there was a high-cost claim. I do know in this particular student group, there were 3 COVID claims that were diagnosed, and they did lead to hospitalizations, but 3 claims out of 45,000 members is really low risk. And in this case, we happen to have some dental plans, and again, that dental coverage would be elective, and so that we expect to see going down, but again, probably reemerging after COVID. So when we think about the cost of student health plans, for the insured plans in particular, we should think about the marketplace and what's going on there and how that impacts your cost. So there are a couple of things to think about. One is there is a limited number of insurers due to consolidation, and this is general within the healthcare industry, even in employer plans. We have a very few number of carriers. When we're looking at projecting claims, carriers are using average trend factors of 8 to 12%. So if your claims look really good and you're predicting for the next year, you're still going to have to try to figure out what's going to happen to those claims in the next 12 to 18 months. And trend is really a combination of several factors that are used in standard underwriting. It includes price inflation, so the cost of prices going up. It includes increased utilization, cost shifting, network contracting, and all of those things have an impact. And again, for fully insured plans, compliance with ADA and state filings is necessary. And we're finding since ADA, number of states, California in particular, is always coming out with new mandated benefits, and these changes have to be priced into the plans. Carriers also in fully insured plans, again, include risk or profit margins to protect the plan from unexpected claim fluctuation. And maybe the reason we have self-funded plans is that in the past, before ACA, if your group was large enough, you actually could have what's called a retrospective premium agreement, where the carrier was willing to share some of the profits or some of the surpluses if claims were really favorable one year and resulted in a surplus. These premium agreements are almost all but non-existent today. So if you did want to take charge of your own claims, the best way to do that is to have a partially self-funded plan with stop-loss protection. And finally, anytime there's unknown within the environment, the way we have with COVID, or anytime there's an underwriting loss, the carriers are always going to be more conservative and less flexible. So when we think about costs, the marketplace considerations are a key point. So with all that in mind, what should you consider now on your campus for 2021? Well, these are questions to really just ask yourself so you're aware of what's going on, and these are factors that you probably already know. So think about what's happening with your student population. Are students, are they online? Are they on campus? A combination? Are they still in residencies? What are you expecting? We're hearing from lots of colleges and universities that they do expect a number of reduction in overall students, and including a reduction in fewer international students as they travel less. What's happening with any subsidized students where you pay for part of the premium for graduate students or PhD candidates? So to the extent your student population is changing in any one of these carriers, reduction in totals, that's going to have an impact on your plan next year. So just to understand what's happening and how you can be aware of that and make sure that it's being addressed. And another question to ask yourself is what's happening with your campus resources. Most student health plans, they have most colleges and universities have staff within either an HR or even in a health center that helps support students with questions. So is the plan administration changing? Is the health center going to be open for the same hours or less hours? And the counseling center, is that still going to be open? Will there be any staff reductions that could impact how the plan is administered? And if your plan has a referral requirement from the student health center, is that still appropriate, or should the rules be changed? And thinking about changing in funding is always out there, and how it affects your overall budget. So given that we're expecting some trends and expecting some changes, what are some mitigation steps that you might be thinking about? How can you protect the plan in the future to make sure that it's available, that it's competitive, and that students can continue getting covered? So one thing to look at is emerging trends in benefit design. Telemedicine for behavioral and medical health is extremely popular within the whole health environment. It's interesting that it's not new. It's been around for many years. It's been around in the employer business pretty regularly for 5 years. And in the student health world, some health plans already include the benefit automatically. But the challenge is it's not been utilized. We looked at some of our data that said the usage of telemedicine was less than 1%. So that leaves a lot of room for improvement. But this benefit has to be communicated, and it needs to be made attractive. There are several ways you can offer it. In some cases, it's available for students at no cost to access the visit, or there could be a copay, low cost. Either way, these benefits delivered online are much less expensive than delivering in person face-to-face at an outside medical provider. So it's something to consider to communicate if you have this benefit or are thinking of putting that benefit in. In some cases, it can actually be offered for very low cost to all your students. Another thing that we're seeing a dramatic increase in is digital behavioral health tools, where a student has an app and can use that app to check in how they're feeling daily. There's another app that's available that provides coaching, that interfaces with the student health center. So given the demand for behavioral health and the unmet needs, it's really important to think of all the options out there for behavioral health. And there are so many new and emerging companies. It's important to do your due diligence, look at what's out there, see which ones fit with your campus. Some of these behavioral health apps will integrate with a counseling center, and others not so much. So again, something to be aware of to help all students and help meet these needs. Another thing that we're seeing to begin popular is making a discount pharmacy program available. These are broadly available in the open market, individual plans, a lot of advertisements for a company called GoodRx lately, but they're actually pretty good because they enable the student to make choices between which is better, to get the drug through the copay or go to an outside pharmacy. And then these programs don't cost, actually are free to offer. So you're not paying anything in your premium to add these plans, and students can benefit from them. And it really depends on how the campus wants to use them. We have a pharmacy program that we're rolling out, and I have two clients where they looked at it differently. One is making it broadly available to all students. It's going on their website. Another one at the health center is just making it available one at a time. As a student comes in, for example, and doesn't have health insurance, then this is a good option for them. Let's think about eligibility. In order to try to manage the adverse selection, if you have a tight waiver, it's recommended that you keep that, even if students are off campus. What this means is they may be able to waive out easier. They may decide to, if you have waiver criteria and you currently don't allow students on state Medicaid plans outside of your state to waive, you might want to relax that criteria. But I think it's important for all students, whether they're on campus or whether they're at home studying online, to be able to have access to insurance, and that you can be assured that they have insurance. Even if a student's studying at home, if they're not well, it's going to affect their performance. If your plan is voluntary, and there were a few of you that have voluntary plans, but most had waiver of some sort, I would say there, just review your eligibility requirements and make sure that that they're reasonable. So, for example, you might want to consider full-time students only, rather than someone taking one online class and then being able to buy the health insurance. And one other point is confirming that your carrier will allow online students to enroll. In the past, carriers were reluctant to do so, but we're finding that most of the carriers we're talking to are going to allow that to happen. That's pretty important. So again, need to make sure that that's happening. And then on plan management, I think most carriers are going to do that. Again, be sure that you're getting reporting on COVID claims, what's happening to your population, and get emerging claim data on a regular basis. So looking ahead, communication is essential. It's the key point. As you think about your messaging to students looking forward to the fall, think about ways you can emphasize the importance of having health care. You can communicate the fact that you have a plan, that the plan is designed for students, and it works with the health centers, and it's a reasonably inexpensive plan. We do think that overall, number of students in student health insurance plans are probably going to go down simply because enrollment is going down. But on the other hand, it could be that some students who are currently covered under their parents' plans now are losing coverage because the parent has been laid off or furloughed. So it might be even more interesting or more effective for students to consider looking at your plan. So talk about the advantages of your plan and how it can help students. Also think about graduating students, helping with gaps in coverage. If they're graduating, most plans today don't have continuation insurance, which is a COBRA-like benefit that sometimes is extended for 3 and 6 months. But a lot of plans have eliminated those when the public exchanges became effective, because then students graduating could always buy a private plan. But those private plans are still very expensive on the exchanges. So some things, there are some states that offer limited duration student health coverage, which might be available, and those are things to explore. And also just helping students navigate the exchanges. It's very complicated. Some states offer 5 or 6 different plans with different rates, and we know that students aren't health experts. So important to help them with that. And finally, really to plan early. Many risk managers are involved in the committees and working with the various stakeholders on campus to make sure that you're getting information and you're understanding the needs of all the people on campus. We think it would be appropriate to start meeting, and I think probably many of you do, in October for getting ready for fall, and at that point gathering information, knowing your claim numbers, getting early projections, and then finally consider, what are we going to do? Let's have in our back pocket, so to speak, a list of plan design changes that we might really consider if we needed to do something to reduce our premiums to keep our plans competitive. So what are those plan design changes? They could be deductibles, co-insurance. That's also a good time to do benchmarking to see how your campus compares with your peers and keep looking at what's going on in the future. And so with that, I'm happy to end my presentation, and I think we have a few minutes for questions. So I'll turn it back over to you, Tim. Hello?
Andrew, do you want to go ahead and moderate those questions or comments that we see in the Q&A?
Yes, I can go through them. Thank you. And thank you, Liz, and thank you, Mark. So first we have Shannon asking, are the average trend factors of 8 to 12% for student plans versus employer plans, or both? And so we would use those for both, Shannon. You know, medical trend is medical trend. The piece that we really want people to take away from this webinar from a financial planning perspective with regards to both programs is we would expect that you would have a very a claims year that is much lower than what you've had in the past, unless you are sort of riddled with COVID claims because of the backlog that Mark referenced. For the quarter of you that are self-insured on your employer plan, you want to make sure you normalize your data so that you don't find yourself underfunded next year. When you take this year's data, you trend it forward, and you have not only that trend, but you also have the release of the backlog that Mark referenced. For the fully insured customers that are on the call, you want to do the same. Granted, it's not your claim costs, it's the claim costs of the carrier, but you are all large enough that you're partially experience rated with your insurance carrier, and you certainly want to arm yourself with at least the knowledge of what to expect as you transition from this year into next year and into the year after, where again, if you have that acceleration of the backlog hitting your claim costs, the carrier is going to use that in their claim calculation for you moving forward. Mark, anything else to add on that? Or Liz?
No, that's very well stated. Yeah, just be aware of what the patterns might look like, and make sure that you're communicating with the finance team and anybody involved in sharing the risk so that they understand what to expect.
Mark, from Maureen, can you confirm that telehealth reimbursement is less than in person? Is this what is found in the Medicare fee schedule?
Yeah, I'm not particularly aware of the impact in the Medicare fee schedule, but and telemedicine is really it's been around for a while, but it's been more on a preventative type basis. Very little is, prior to this year, very little was really used extensively. So it's kind of an emerging practice. Obviously, it should be less, and we'll see how those trends follow up. But it is kind of widespread telemedicine is relatively uncharted territory for us.
So what we're seeing, Maureen, in the Northeast is we are seeing that on a per unit basis, telehealth is less expensive than in person. What we're concerned about, frankly, is that we're starting to see that as the demand for in-person has been impacted by COVID, there is a little bit of a bubbling up of an increase in the unit cost for telehealth as healthcare systems are sort of reacting to the increase in demand and their concern over losing the revenue of in-person versus the revenue of, telehealth. So it's a great question. It's certainly something that we're going to have to watch as the impacts of COVID continue to sort of come forward and the market reacts to them.
And Andrew, I just add that some student health centers are actually considering offering their own telemedicine benefits. So that's also a really good option to help students that are away from campus if you don't have an outside vendor. So there's a lot of interest in doing that. So we'll be curious to see how that works out. Kind of a new trend.
Liz, Shannon clarified a little bit. Do you have a stronger trend figure for student health closer to the 8 or closer to the 12 on trend?
Yeah, and I'll look at it two ways. One is if your plan is fully insured, you're stuck with the carrier's trend factor, bottom line. And I would say that on average, the trend factors from the carriers that do student health is at the high end of that range. So I would say closer to 10 to 12%. And, the other thing about the marketplace, if the major carriers, the UHCs and the Aetnas start losing money and the Anthems and the HCSCs, and I'm hearing that they're concerned because some of their clients are not doing well financially and are dragging their premiums. So the fallout from the major carriers not having losses is that's going to trickle down to the student divisions. So it's going to be really challenging to get negotiate good renewals for fully insured. So that range is for high end for fully insured plans. I think if in a self-funded plan, we would tend to use the lower range. That's whether an employer plans or student health plans. We know that carriers tend to overstate the trend factors, so we would use a trend on the lower end.
Thank you. Celia, the pharmacy program that Liz mentioned, I believe, was GoodRx. Liz,
actually,
what's the other one that you have?
GoodRx is the one that I've seen lots of ads on. The one that we have negotiated a national agreement with is called CleverRx. So they're different from GoodRx. It's brand new. We're just launching it now, and it's getting a lot of interest. So that's exciting. But a couple of reasons why we decided to partner with this vendor is, number one, they basically don't accept rebates. And people that know the pharmacy industry know that they're notorious for, issuing rebates, and they do get a per script fee, but they don't get a rebate. So the thinking is they can be more competitive. The other thing is we can get data from our clients that opt for this, and that basically allows us to know how much students are saving, both campus by campus and on aggregate. So we're going to be looking at this first year and see if it's successful, and hopefully we can report some good results back out to the market.
Another question here. Do we have a recommendation regarding coverage of serology testing as a screening tool? Does our recommendation for coverage of this testing change if the university requires serology testing as a condition of enrollment?
I would definitely cover all testing. The carriers have basically agreed for the basic positive, negative testing, but I think the serology testing is very important, and I think this is something you can definitely negotiate with the carrier. You should be able to do that. Whether you're going to do it at the health center or if you can negotiate arrangement with a local provider, maybe your consultant can help with that, but that's what I would tend to basically try to definitely cover it.
We would agree on the employer side, particularly as they're starting to have some real discussion as to what's allowed from the human resources and legislative standpoint by way of testing. So we would agree. And then lastly, on the discount program, Liz, is the program in conjunction with a PBM or in lieu of a PBM?
It's in addition to a PBM. They basically can go to any pharmacy. All the major chains are covered. I suppose, you could carve out your PBM. That's an option if you really want to save money. We know that pharmacy costs represent on average 20% of student health claims. I wasn't thinking of going that direction, but generally it's a situation where you might have the case, particularly with a high-cost drug. We know that students have behavioral health drugs that can be expensive, autoimmune drugs that can be expensive, Truvada we see a lot of, and some student health plans are really upping up those copays on those high-cost drugs. So this might be an opportunity where the student can actually save money, go to the pharmacy, well, here's what my copay is, and here's what my app says you can get it for. The nice thing about using the pharmacy, if the student does get the prescription through the app, that claim doesn't hit your plan, so the plan saves money as well.
And we see the same thing on the employer side. With the amount of complexity in the pharmacy world, the ability to really do a deep dive on your specific prescriptions that your employees are using and who the best pharmacy benefit manager would be based upon their discount program and their rebate program is essential to really managing this, especially if you're in one of the self-insured plans, as if you're fully insured, there's usually a little bit more complexity on being able to carve them out. So Michelle, I think we are all set. Yes, Steve, I believe there is going to be a link to re-listen. Michelle's probably the best to handle that, and it's a good segue. Thanks, Michelle.
Exactly. Perfect segue. Thank you so much. A very helpful information. It's a big higher ed risk management topic, obviously, as we head back to campus and as things are ever changing, and just a real highlight of the impact of COVID-19 on not only today, but the future. So thank you for sharing the information. And to Steve's point, good question. Yes, we will be sharing today's recording and materials in the coming days in the URMIA library. Thanks. Tim, can you wrap us up?
Okay, and thanks. Terrific presentation today. And that concludes our event. On behalf of URMIA, I want to thank everybody for their participation in today's webinar. When I end the webinar, your computer will be redirected to an online survey. Please take a few moments to complete this. This will help us plan future quality programming. And that concludes our event today. Thanks again for joining us, and have a great week.